this up. Okay. So Paulin, I'm very excited to have you here today. I'm sitting here via audiophone and video, and we have the opportunity to meet Paulin face to face. And I wanted to thank you for taking the time to do some Q&A around the Rwandan healthcare system. So thank you, Paulin, for being here.
Thank you. Thank you for having me.
Great. Let me start off. Can I ask you to tell us a little bit about yourself? We know from our correspondence with the teams that you're a senior program officer in the Gates Foundation's Global Development Integrated Delivery Team. And I thought we could have you start us off by sharing a little bit of background about yourself and how you got here.
Sure. So I'm Paulin Basinga. I'm from Rwanda, and I'm a medical doctor, and I was trained in Rwanda. So I started my medical school in Rwanda back in 1995, just after the genocide, and I graduated in 2001. And after that, I worked for the National University of Rwanda, the University Hospital, before joining the School of Public Health in Rwanda. And then from 2002 to 2012, 10 years, I worked for the National University of Rwanda School of Public Health, where I was the deputy director in charge of research. And meantime, while I was working, I went to the US doing a sandwich program where I did my MPH and PhD in international health at Tulane University. So, and then I joined the foundation early 2012, first joining the HIV team, and then now moved to the integrated delivery team as a senior program officer.
Fabulous. Well, so obviously you come from a long history of being in Rwanda during the rebirth and rebuilding of the health system, and not only the health system, but the social and political order. So I think your lens is a very exciting and opportune lens for us to take a look through what's happened in Rwanda and have the teams be able to think about the concepts that you have and you can share with us that they can use in their own work on the ground in their respective countries. So maybe let's go ahead and jump right in. And we have an opportunity for our teams, they asked some questions previously, and one of our projects took a very broad approach to start us off, which is a great approach, and asking about what the role is of national political leadership in affecting the agenda for health around Rwanda.
So I think what I would really say here is that the political leadership played a key role here, because it's very, very important to note that, because any lesson that we can learn from Rwanda may probably not be applicable in another country, because Rwanda is a very small country with 30 districts and quite well managed, and the fact that from the top, President Kagame is a very very strong leader with very good governance and accountability record, and just bring that accountability down to the village level. I think this is very, very important. And then also the fact that the leadership has pushed people to create ownership and making sure that they all manage for results is something very, very important to note here, because President Kagame each year sign what he calls imihigo. Imihigo is like a performance contract with the mayor of the district, of the 30 district, and on those contracts, those are annual contracts. They include both health, economic, and social indicators, and those health indicators will be tracked by everyone. And then at the end of the year, the president will meet with all those leader at administrative level who work very closely with the leader, the health systems, to just track their progress and rank districts from district number 1 to district number 30. And people will be very demanding if their leader at the district level did not deliver on those indicators. I think it's very, very powerful. And also something which we need to say here is that the fact that Rwanda in 2006 decided to decentralize in a very effective decentralization, where the country was split into 30 very functional independent districts, and those districts have also decentralized their activities, especially for the health sector, where you have health center being very independent in terms of their financial management, etc., where a nurse at the district level can hire and even fire staff, etc. But in a very accountable way to the district, etc. I think that's also created, something very special in Rwanda, which also helped to justify all this progress. While if you look at the other countries, it's very difficult to keep the district, the number of districts, because in some other countries you'll see that, if a leader want to increase the number of entity receiving funding from the national government, they will just create additional districts, complicating the whole, implementation of the health sector plans.
And you touched upon some really good concepts that I think all three teams can relate to. Specifically, the health leadership. You describe the social and political contract that they take with the leaders, the traditional leaders. When you mention Imihigo, is that how you pronounce? And I think
administrative leaders.
Administrative leaders. Okay.
Yeah.
But I think that accountability is something that is interesting to learn about, and I think the teams could be interested to hear more about that. The decentralization, I know that's happening across multiple countries in Africa, and I think the lessons have been learned from what you're describing. The three groups that we're working with all have very good relationships with the government, and I think one of the biggest questions they have, despite the fact that they already have great relationships, the questions that they have is how should they best interface with those leaders at all of the multiple levels, so at the facility, district, regional, and national level. How can these groups make sure that the government is engaged and accountable for what they have promised that they're going to do, and ensure that there's follow-through? What has been experience from your perspective that they might learn from?
Sure. So I don't think the problem is more on the side of the NGOs working in certain areas. The problem may probably be at the government level, and sometimes it's very difficult to make sure that the government is accountable. But I can understand that the groups have very, very strong and good relationship with the government, and if the government is not accountable to start with, it may be very difficult to pull them there. But one suggestion I may have is that first of all, is really to start planning with the government at the beginning, because most of the NGOs, when they start projects, they define interventions, at the grant proposal stage, right? Because when you are applying for funding, for paper, for the Gates Foundation, for, I don't know which other funding organizations, sometimes you are working on a very, a very tight schedule, etc. You don't have time to engage deeply with the government to make sure that they will take those solutions as the solution to their own problems, and they will be part of the solution development. But then most of the time you see NGOs coming to the government a posteriori, telling them, hey, look, I have this money, I have this fund, I have this project, even most of the time without telling them exactly how much money you have, what kind of activity you are going to be implementing, etc. And then the government, most of the time they feel like they are not, this is kind of another project that they are being imposed. So, I think, some effort need to be done really at the beginning, even when the project has been awarded. When you come to discuss with them, if you have some flexibility to just engage them in a very constructive way, showing them that, even allowing their ideas to be there, and then also, opening the doors for them to be, part of the solutions, I think that will help. Yeah.
Sure. Great. Great. And and you're talking about ideas, and I know one of the ideas of one of the teams in Nigeria, SFH, is testing out performance-based incentive for community volunteers to help drive ANC attendance, facility delivery by skilled birth attendants, and at the postnatal visits. So given your experience and expertise in this area, I know you sent a few different articles which were great reading for the teams. This team is wondering, how can they reduce fraud, including connivance between health workers and community volunteers? Very specific.
This is a very tough question, right? So this is, a question that we've even, struggling with in Rwanda, and we were very lucky in Rwanda. here I'm not saying that there is no fraud, probably, but the fraud is not, we've tried to test some intervention to see if there is fraud or not, etc. Trying even to do some outreach at the community level to verify service received at the facility level, etc. But we found that the fraud was very, very little. But this is because in Rwanda particularly, this is a context issue. There is, no tolerance to corruption policy within the government, and even at the national level, if even a minister take government money, the minister goes to jail, and this goes down up to the community level. So that helped a lot.
Yeah.
But then at the other side is that we've tried to like for the community health workers, we've tried to include them into the decisions and try to strengthen the centralization process, showing them that, look, this is a way that you are going to sustain your own program. So, for example, for the community health worker incentive program, the money is not going to community health workers. So we've created cooperatives of those community health workers so that, like you have 20 to 25 community health workers, they group themselves into a cooperative, and they have a legal status to open that cooperative. And then when they get the money, and the money only 30% will go directly to them, they can split that money among themselves, and then 70% will go to the cooperative, and they will invest that money to do income generating activities, so that it's kind of a community level activities, and then backed with a very strong supervision from the district level. So the district will come every month to verify the quantity, etc., etc. So those are different combination of things that showing people that, so this is your own program, and you need to make sure that you build it in a sustainable way, and then you have to put check and balances in place as well.
Yeah, and you're talking about that from all levels. So from the top, from the leadership level down to the community level, which I like to hear. How do you engage community members in that accountability and ensure that their parts are not, it's not just coming from the top, but it's coming from their peers as well. So the cooperatives, I think, is something that would be of interest to delve into a little further at some point.
Sure.
And that also kind of mixes back to another team's question. When you're talking about engaging communities and showing that accountability and honoring that sense of community, the experience that Rwanda has had with their cadre of volunteer community health workers is phenomenal, and I think it's been a model that other countries are already starting to explore and test out. How, and this is a very broad question, but how was Rwanda, and how does Rwanda continue to be successful in mobilizing, motivating, and really maintaining that very large cadre of health workers?
I think the secret here is that it's coming really from the community. So as I told you, is that Rwanda is organized in 30 districts, and then within districts you have sectors, and within sector you have cells, and within cells you have villages. And in the village, it's an agglomeration of 100 to 150 households, and then those people within a village, they really kind of live together. So they meet regularly for what we call umuganda. So umuganda is a traditional activity that the government brought back, which is at the last Saturday of the month, everyone from the same village will gather together and do some community work to clean their their village and discuss any issues, etc. So that community of 150 people are the ones who elect community health workers, and then there are three community health workers per each village, and their binom, what we call binom, is one man and one woman, and then an additional community health worker. So those three community health workers are chosen by the village, and they are very much respected. So they kind of call them, doctor. They are kind of, recognized. They are, it's a pride to be a community health worker. And then this, it's linked with a very strong support from the national level, where, once a year, the president will call all community health workers, bring them into a stadium, and greet them and say thank you to your work and we appreciate very much, etc. And there will be a national recognition of community health worker role, and the government try to give them like free participation to, free access to the community insurance scheme. So they add them as the poorest of the community, even if they're not poorest, but to give them some advantage. And so they also have a program with cell phones where they give them cell phones, but those cell phones are not, they get the cell phone for free, and then the government negotiated with a mobile phone companies to give them, units to call free of charge, but it's mainly to send health information system on a monthly basis to the health facilities, but at the same time having a cell phone at the village level and having battery charger, etc., etc., just put that person in a certain level at his community, etc. And then adding the fact that they can create their community health worker cooperatives, and then within those cooperatives they are free to use their money as they want, and then giving them opportunities to open a small shop close to the health centers where patients who are hospitalized can buy their stuff there, so that will be an opportunity for them to be visiting the facility, allowed to report, etc., etc. So I think it's a lot of combinations that are put in place, coupled by very strong laws protecting them, and just that sense of community that keep them going. And here I want just to be very clear that they are not part of the formal civil servant in Rwanda. They are not part of the payroll of the government, because we are talking here about 45,000 people. If you add them into the Ministry of Civil Servants and payroll, it will be just a huge amount of money for the government. So they're not part of that. But there are different incentive schemes that are tied to that, and someone is and because their package of services are so diverse, and they have drugs in their houses, etc. So it's a very huge pride, because people come to them to receive family planning, come to them to receive treatments for malaria, etc. So they have a consideration, at the community.
It's an incredible system, and there's so many questions that pop to mind as you describe the incentive structure, and who they're accountable to, and that they're not part of the formal system, but yet they're doing a phenomenal amount of work for the system, based on their respect and motivation as a community. One of the things that we might want to explore as a team is to really unpack it a little bit more, and how do you sustain that level of commitment and motivation? It might be something that would be interesting to hear from your perspective. How has anybody studied sustainability, and how do you continue to have that run? And maybe it is something that is self-sustaining. It's something we can explore. Paulin, I'm conscious that I've kept you here for over 15 minutes. So this was a great whetting of the appetite, so to speak, for our teams to really hear a little bit about what is happening on the ground, and what the experience of Rwanda can bring to the experience of these three teams in Ethiopia, Ghana, and Nigeria. A quick parting note, just so we can wrap up the bookends, and we got a brief introduction of your experience at the beginning, and I thought I would ask you and share with the team that you just had a recent event that brought maternal and child health closer to home. Paulin is now proud papa of twins, so I just had to ask, how are they doing?
They're doing great. They're doing great, and it's just a little bit challenging for an African dad to raise two, newborns here in the US. So I have learned a lot, changing diapers and cooking and, washing them and taking care of them. It's fun. Yeah.
Great. Well, thank you, Paulin. And I appreciate you speaking with us today. And we look forward to unpacking a little bit about what you shared on a future call with our teams.
Sure. Thank you. That was a pleasure.